Welcome to our presentation today on COVID-19 vaccines and children. I'm Ellen Hardigan O'Connor, history professor and associate dean for grad students and postdocs here at UC Davis. And I'm here to introduce our speakers, Dr. Dean Blumberg and Dr. Lena Vanderlist of UC Davis Children's Hospital in Sacramento. And I am so pleased to say that our speakers are the hosts of Kids Considered, UC Davis Children's Hospital podcast, where they discuss child health topics of interest to parents. So really, they're the perfect panelists for today's event, which is intended to provide valuable information and answer questions that parents have regarding the COVID-19 vaccine. So Dr. Dean Blunberg is professor and chief of pediatric infectious diseases at UC Davis Children's Hospital. Dr. Blumberg is also head of infection control at Shriners Hospital for Children in Northern California. His main areas of interest are preventing and treating childhood infections. And Dr. Lena Vanderlist, pediatrician at UC Davis, her clinical interests are in adolescent medicine and creating a medical home for children with complex medical needs. Her interests also include working with the media as a tool for patient and family education. They both have done a lot of work in advocacy as well. So their expertise is, I think, exactly what's needed for today's event. And I'm going to hand it over to them for their presentation. And then we'll follow up with a Q&A, both drawn from questions that have been sent in advance, and then any questions that you haven't to put in the Q&A today. So thank you so much.
Thank you guys for having us. We're really excited to be here and talking about our most favorite topic right now and super important topic of COVID-19 and how it impacts children and really the importance of vaccines and for kids.
Mm-hmm. Yeah, so we're going to show an outline of what we're going to talk about this morning. We're going to talk about the current status of COVID-19 in the communities and talk about several issues related to the vaccines, including how well they work, concerns about side effects, some myths about the vaccine, and why it's so important to vaccinate children. And then also touch on the variants, because they've really been in the news lately. So the first thing I'd like to just show is what's going on in the US. The red areas, the red counties, are where there's high rates of transmission. And you can see a lot of this is in the Midwest and the South, and some of the rural areas, and a lot of these have high rates of transmission because there's relatively low vaccination rates. And here we are in California, it's yellow, it's moderate rates of transmission, but we've done a pretty good job here in California and specifically, in the Sacramento area.
We wanted to highlight a little bit about how COVID-19 has disproportionately affected communities of color and different socioeconomic groups. And I don't think that's new information to any of you listening. But here, this slide basically shows us the percentage of this group that's been impacted by COVID-19 compared to the percentage they make up of the US population. And so this is case rate. So you can see here that the Latinx population has been so hard hit by COVID-19. And we also see that there is a high proportion in the Black and African American community, and whereas white or non-Hispanic make up less of the overall proportion. And on the next slide, it looks at fatality rate or death rates. And again, we see the same thing where the Latinx population had a higher mortality rate than in their percentage of the general population, as well as in the Black non-Hispanic community. And so this just highlights the importance that I think all of us knew to getting vaccines to these communities quickly. And that was something that California really laid out as a priority, making sure that we had equitable access for all of these groups. Next slide, Dean. Here, this looks at the CDC Social Vulnerability Index, and that looks at 15 social factors that include poverty, if people have access to a vehicle, if they live in crowded housing. Here you can see the orange line is average, and the blue line would be what we consider high vulnerability populations. And we can see that the biggest differences between average and those high vulnerability populations are when we're having these surges. And so, you know, back when we had the first surge there in July, and then again in like December, January, we see that these gaps really widen. And that's when we see the high mortality rates, large case infection rates. And we think that this is due to a variety of different things, social factors. So living in multi-generational housing with lots of family members, obviously lack of access to good health care, the proportion of these communities that work in as essential workers, so they weren't able to stay home during the pandemic. This all was related.
I just want to show where we might be going with this also. This is one of the models that's been most reliable. It's from the University of Washington, the Institute for Health Metrics and Evaluation. And it shows since the beginning of the pandemic, where we had the first wave in April, the next wave last summer, and then the biggest wave occurred in December and January of this year. And we've come down very nicely, and the modeling going forward really is suggesting that we're going to have maybe a very slight rise going forward, probably due to the new variants. And then especially what we're curious about is as we enter the fall and winter months, where we know that the coronaviruses are more commonly transmitted. So we'll see where we go from there. But it looks like things are going to be relatively smooth, at least until then. I wanted to go over briefly about the life cycle of COVID-19, of the novel coronavirus. Up here, it shows the spike protein, which serves as the attachment factor from the virus to our ACE2 receptors, which are in our respiratory tract. And this allows the virus to fuse with the cell membrane and enter the cell. And once it enters, then it releases its RNA, which is then transcribed by our host cells, and then it replicates the RNA, and it's then packaged up and released where it can then infect other cells and other people also. But really the key here is right there with the receptor where the spike protein binds to the receptor. And so that's really the key portion to focus in on when we're developing vaccines. So in terms of how vaccines work, the first thing that happens with any vaccine is you administer the antigen. So in this case, it's the antigen is the red ball with the spikes. And then the next thing that happens is that the macrophage here, one of the immune cells, ingests the antigen, and then it presents this via these blue projectiles to other cells, to the T and the B cells. And then the T and the B cells, here it's showing the B cells, the plasma cells, then make antibodies towards it. And the idea is then that the antibodies are against the pathogen, and the Y-shaped yellow antibodies then bind to the pathogen and neutralize it so that we don't get infected, or if we are infected, it's a much milder case. And then there's also T cell immunity. That's a little bit more complicated and may not work quite as quickly, but that's also important for memory. So the idea with vaccination is we get development of immunity against the pathogen without actually suffering the actual disease. So when we look at these vaccines that we're talking about against COVID, these vaccines, the mRNA vaccines, enclose the mRNA that encodes for the spike protein in a lipid nanoparticle. When it's injected into the muscle, the lipid nanoparticle makes sure that it's taken up primarily by the immune cells. And then once it gets into those cells, then the messenger RNA is released, it goes to the ribosome, it's transcribed, and there's your spike protein. And so again, the way that this is shown is that we do the injection, the messenger RNA is made within our own cells, and then it's presented, the spike protein is then presented to B and to T cells, and that's how we get the neutralizing antibodies as well as the cell-mediated immunity. So it's a novel way to make these vaccines. These vaccines, this platform, this mRNA platform was developed for years in anticipation of a pandemic when we would have to develop vaccines relatively rapidly. Here's the efficacy of these vaccines in the real world. You can see these have been studied in several different countries. Different vaccines are shown here, and you can see that the fully vaccinated people, about 90% plus protection with the mRNA vaccines. And again, symptomatic infection, again, more than about 90% protection. These vaccines also protect even better against severe disease, hospitalization, and even better than against death, for example. So when we're doing these comparisons among the vaccines, I just want to caution people that these vaccine studies were performed at different time periods with different intensity of transmission and in different areas, geographic areas that had different circulating variants. They were at different geographic locations and different populations. And they also had different study methodologies, and the confidence intervals may overlap. So really, I think the important thing is that the efficacies are not really directly comparable to each other. They're only comparable within their own studies where they're compared with placebo. So I wouldn't get caught up too much with the numbers that you see. These are the vaccines that are available in the US. The one that we'll focus most on today is going to be the Pfizer Biontech vaccine. That's a 2-dose vaccine with a 21-day interval. We'll focus on this one mostly because this one is the one that's approved for emergency use authorization by the FDA for 12 and up, whereas the other vaccines, the Moderna vaccine and the Johnson & Johnson adenovirus vaccine, both of those are 18 years of age and older. So for children, they're going to be getting this vaccine here. So for the vaccines, any vaccine can be used when indicated, and we're just starting to study the mixed series right now. The vaccine protectiveness for children, for the 12 to 15-year-olds, you can see the data here. There were no infections in the vaccine group. There were 16 in the placebo group. So out of this cohort of 2,000 study subjects, the vaccine was 100% effective. We don't have clear numbers on immunologic correlates of immunity, but it's always nice when the antibodies are very high. And so what this study also looked at was the geometric mean titer shown here, the antibody values in the vaccine group in the 12 to 15-year-olds. And then the comparator group were young adults, 16 to 25-year-olds, where we know the vaccine actually works. And you can see that there's a higher antibodies in these younger individuals. So that's also reassuring about how well the vaccine will work here. Getting a higher antibody value is probably going to result in equivalent or better protection. And you can see it was 76% higher antibody values in this group compared to the older age group.
So now I'm sure that many parents want to get into and talk about what are the side effects that we're seeing in our kids 12 and up so far that have been getting the Pfizer vaccine. So let's get into that a little bit. So in the initial study that they looked at, the most common were the symptoms that probably, I'm guessing many of you have already been vaccinated, just like we have, and probably very similar to the symptoms that you yourself experienced. So local reactions that occurred within the first week after immunization were the most common. So pain and tenderness at the injection site. Systemic reactions also occurred frequently. So that was going to be most commonly things like having fatigue, a headache, a low-grade fever, some muscle aches, just kind of feeling run down. Most of these symptoms only lasted 1 to 2 days in kids, just like in the adult population. And severe reactions were more common in vaccine recipients, but that was just something that was reported as interfering with daily life. So there was about 11% versus around a 2%. And again, that mostly just related to being really fatigued, fever, headache being the most common. So of course, this is the big thing that everybody was talking about, right? And as a pediatrician, for both of us, when these cases started coming out, your heart just kind of like sinks, because of course we all continue to and did recommend getting this vaccine. And so anytime you hear about a possible inflammation of the heart or something, it gets really scary. And thankfully, the punchline is that this is exceedingly, exceedingly, exceedingly rare, and we are still encouraging immunization. But to talk a little bit more about it, there does seem to be an association between the COVID vaccine, the Pfizer mRNA vaccine, and myocarditis and pericarditis. And so what this is inflammation of the heart muscle, or the sac that the heart is contained in, the pericardium. And this is not unique to a vaccine reaction. So we see this relatively commonly in kids after routine viral infections, after COVID-19 itself, but also after things like influenza and some of the other more common viruses. So we do know that it occurs more frequently in young men, so most commonly in males under 30. It does seem to be in the 1 week following it can be after the first or the second dose, but it more commonly occurs after the second dose. And many of these cases have been hospitalized, but it does just last for very short periods of time. So usually for a couple days. They don't require any medication besides usually like an NSAID or like an ibuprofen type of medication to help with that inflammation. And of course, we're still collecting data on this. So I think it's safe to say that the risk is slightly higher than normal, but it's still almost zero. So when you look at the actual case rate, it's 0.0005% in the risk for developing this. So this was a nice graphic that looked at the predicted versus cases prevented versus myocarditis when you're giving 1 million COVID vaccine doses over 120 days, and comparing that females who we know are lower risk of developing this complication to males. And what you can see is there's a really large number of COVID-19 cases prevented, and as a result, hospitalizations and ICU admissions prevented. And those at the bottom there are how many myocarditis or pericarditis cases we may end up seeing as a result of the vaccines, the vast majority of which will resolve with a brief amount of time, rest, and some NSAIDs. Of course, as a pediatrician, if your kid experiences any of these symptoms, so that's going to be chest pain, palpitations, feeling like their heart's racing, feeling short of breath, we would absolutely recommend going to see your physician. And there are a few tests that we have been recommended to run. So that's an EKG to look at the kind of the heart rhythm, and it gives us some really good signs to point us towards if this is happening, and maybe some blood work. So there's a troponin, which measures your heart inflammation, and some inflammatory markers. And so we do have good guidance on screening for this should your child experience any of these symptoms. And just like I said in the beginning, this was not taken lightly by anyone. So as soon as we started to see some of these cases, lots of organizations got together. So the Advisory Committee on Immunization Practices met with the CDC and the American Academy of Pediatrics and family physicians and OBGYNs and American Medical Association and basically everyone that you could think of. And they reviewed all of this data. And what they found is that the benefits of immunizing against COVID exceedingly outweigh the risks of developing myocarditis and pericarditis. And so we should all continue to encourage our patients to get vaccinated. And like I mentioned before, the risk of these two things with COVID-19, if you get infected with the virus, is still much, much more likely than if you'd get it from the vaccine alone. And then just yesterday, this came out again from the ACIP saying that we continue to recommend the mRNA vaccine for all age groups. All right, so let's get in. This is a fun part to some of the myths that I get to see in my office or hear about and answer in my office every day. And you know, these are not to be like we're not joking or anything when we talk about this. Of course, parents are going to have valid and questions about vaccine safety and all of that. So a lot of people will say that the vaccines were just developed too fast. Like, you know, that usually it takes many years for a vaccine trial, and this took, you know, months instead of years. And I think that is a valid concern. Dr. Dean mentioned this a little bit in the morning at the beginning of the session, that really an unprecedented amount of effort and time and money went into this. And although we haven't used mRNA vaccines on a large scale like this before, they have been studied in humans and in different trials in HIV and rabies and Zika and some other things. So this is not a brand new technology. And all of the initial studies had, you know, over 30,000 individuals. So they were really robust studies that looked at all genders, races, backgrounds, so that everyone would feel that they had been covered. And, you know, in the beginning, before we started vaccinating children, we had a nice little trial run with, you know, at this point, over 300 million doses being administered. And really the safety profile is very, very, very good. And so I try and present that data to families when they ask about it being developed too fast. Some people wonder if the vaccine can give you COVID-19 itself. These are all inactive vaccines, so they're not live vaccines, so it is impossible to actually give you the virus. Some have questions about it actually going in and altering our own DNA. And so what's nice about these mRNA vaccines is that the messenger RNA is deposited into the cytoplasm of the cell. It actually doesn't go into the nucleus at all, where our DNA is housed, and it is broken down there. So there is really no way that it can get in and alter your own DNA. Some people want to get the first dose of the vaccine, and then they say, well, I've heard that there's more side effects, more fevers with the second, and so I'm going to wait on getting the second. And really, we're encouraging everybody to complete the full series of the vaccine. So if you have young children, you know that booster vaccines are super common. So your kid isn't going to just get one of their DTaP vaccines, right? They need all of them to ensure their adequate immunity, or they're not just getting one of their MMR or their chickenpox, they're always getting two. So we know that with that second vaccine, it does boost our protection against the virus. This is one that we're hearing a lot about. The vaccine causes infertility. Just as like an N of one, I know that doesn't happen because I am pregnant after the getting both doses of my COVID vaccine, as are many of my colleagues. But you know, this is a valid concern for parents, and I think that the confusion arose when there was a kind of a false report on social media or in the news that the spike protein mimicked a protein that was responsible for the attachment of the placenta. And this is just not found to be true. And so really all of the data suggests that there are no issues with infertility, and there isn't really a scientific explanation that would make sense for why there would be after the COVID-19 vaccine. During the Pfizer initial trial, and we're getting much more data about this now, 23 of the volunteers in the initial trial did get pregnant, and only one of them suffered pregnancy loss, and she was in the placebo group. So she did not, she was not in the actual vaccine group. Parents will ask about menstrual cycle irregularities, which is also just like anecdotally described after the vaccine. And I, obviously, if people are experiencing that, they're experiencing that. And I liken it to, you know, when you're really sick or you're in a really stressful situation, our menstrual cycles can sometimes get thrown off a little bit. And everyone that's experienced this, they've returned to a normal cycle that I have personally experienced. And so that's not something that I tell parents to worry about, and I reassure a lot about the infertility. Question. I don't need to be vaccinated because I'm immune from having COVID. This is a great question that families have if they already have had the virus. Why do they need to get it again? And we know that immune response following immunization is equivalent, if not better, than the immune response following infection. So just like you may have had influenza in the past, you still get your flu shot every year, or at least I do. There can be, of course, now with the variants, we do know that there is good protection after the vaccine. And so we don't know if our natural immunity may not be as good against some of these variants. And we know that we have a stronger and more robust response from the vaccine itself. So even if you've had COVID, you should still get vaccinated. This is one that we were kind of working out in the beginning when we started rolling out the COVID vaccine. We would delay kids' other routine childhood immunizations, which was really tough in our office because a lot of kids have stayed home from the doctor for the last year and are maybe behind on some of their really important immunizations like their HPV vaccine, tetanus boosters, meningitis shots. And you do not need to delay getting those and getting the COVID vaccine. So you can get them on the same day. You can get them a few days apart. So make sure that you check in with your physician and get your kids all up to date on all of their vaccines. I hope that I don't have to go too much into this since I'm talking to a group of professionals and graduate students, but there was some social media videos and things going around about people feeling like they were magnetized after getting the vaccine, and so much so that the CDC actually released a list of ingredients on their website showing that there are no metals included in any of these vaccines, and it definitely does not implant a microchip. And we still don't know the long-term side effects. This is a common one and a totally understandable one. And I think that this really involves, to talk about this, we have to go back and have a look at like the history of vaccines. So nearly all long-term side effects that may be possibly related to vaccines that we've seen in the past happen within the first 2 months after getting that vaccine. So it's not something that we've ever seen will show up like a year or 6 months after. And so that's why all of these trials follow kids for at least that 2-month time frame. And so really, we do have data on long-term effects because with vaccines, long-term effects is considered that up to 2-month time period. And so we have seen, while we can consider that this myocarditis, pericarditis happening about a week out, maybe a little bit longer than that, that could be a little on the longer term side. But really, most of these reactions are going to happen after. So if it's anaphylaxis, a severe allergic reaction, local reactions, systemic reactions like headache, fever, things like that. And so now, we have immunized enough kids that we have that 2-month follow-up data.
So let's see how we're doing with vaccination rates. This is from the CDC showing that in the US, more than 330 million vaccine doses have been administered, and this accounts for at least 55% of the total population has had at least one dose. And for those for whom the vaccine is indicated, 12 years of age and up, 64% have been immunized. Of course, the initial rollout targeted those 65 years of age and older. You can see we've done an excellent job with that in the US. And then this map from the CDC shows the states that have the highest rate of immunization. The darker blue areas are the highest rates. And so you can see Maine, Vermont, Massachusetts, and Rhode Island lead the way. But California is doing very well also in terms of vaccinating. So we've done a great job. And it's really these lighter areas that we worry about that have lower vaccination rates, these are where there's continuing outbreaks and continuing relatively high rates of transmission that are occurring. This shows the daily number of vaccines administered in the US. Of course, when we first started, there was a shortage of vaccines. That's why they were prioritized. And then you can see right around in April, the supply caught up with demand. And so since then, there's been decreasing numbers of vaccines administered, since anybody now can get a vaccine. So we're doing great with vaccine supply in the US.
So why are we here talking to you about why you should get your child and your adolescent and hopefully soon to be child vaccinated against COVID-19? Because as adults and elderly patients or people are getting vaccinated, luckily those numbers are going down, and we're seeing a rise in the numbers of COVID-19 cases in younger children. So in this graphic, you can see the percentage of 18 to 24-year-olds is really the highest right now. Again, here we've seen it move up over time. So from the 20% to 33% in May 2021, and that's for 12 to 29-year-olds. And a lot of people say, well, COVID in kids isn't a big deal. I feel like I hear that from patients and families all the time. Like, they don't get that sick. They don't, they don't have a high morbidity or mortality from this. And, thankfully that's true. But it isn't nothing. It's nothing to scoff about or say that it's no big deal. So one thing I like to compare for families is that this year, right, no kids were in school. We were all masking. We were all doing a really good job of distancing. And to compare, for example, this year, and Dean, correct me if I'm wrong, one child died from influenza, where we normally see 200 children die from influenza.
Right, and that's in the whole US.
And that's in the whole US. And we've seen over 300 children die from COVID. And that's even with doing all of these mitigation strategies. So what would it have been if it was like a normal flu season, right? So it's nothing that, for me, I'm going to protect every single kid I can from developing this and potentially getting these severe complications. So MIS-C, or multi-system inflammatory syndrome in children, is sort of the feared and dreaded complication of COVID-19 in kids. It's a hyperinflammatory syndrome. It's similar to Kawasaki's or some of the other inflammatory syndromes we see after other viruses in kids. It occurs usually a few weeks following the infection. And most of these kids are very, very sick, will need admission to the ICU and long-term care and have sequelae that last. So they're going to have things like high fevers, rashes, abdominal pain, blood pressure instability. And most of these are in older kids, so the 12 to 20-year range, which, lucky for you, you can get your kid vaccinated and prevent this horrible complication. And unfortunately, again, this is one of the things that disproportionately affects our Latinx and Black population. And so even more reason to get out equitable vaccines to these communities. Also, even if it's not MIS-C, we know that now as pediatricians, if kids have had a symptomatic COVID infection and they're athletes, we know that this virus really affects the heart. And so we're recommending that all parents get their kids cleared by their doctor before resuming competitive sports. And so that's something to keep in mind as well. We do know that deaths continue to occur in this age group that's not vaccinated. So here's some of the more recent data as well. Again, looking at that younger age group, the 18 to 30-year-olds have been having an increased rate of mortality.
So we've got the vaccine for 12 years and up, but there are studies that are ongoing for younger children. Moderna has done studies 12 to 17 years old. I haven't seen those results, but they say they're going to apply for an emergency use authorization. They missed June, so they didn't apply yet. So maybe this month in July, they might be applying. And the turnaround time for that from the FDA is usually about a month. So once they apply, if everything goes smoothly. So we may have a second vaccine available for 12 and up. And then for 5 to 11 years of age, there's studies that are ongoing from both Pfizer, Biontech, and Moderna. Both of these have been studying a lower dose of the vaccine because obviously 5 to 11-year-olds are smaller. So I'm assuming that they're using a smaller dose because the full dose might cause too many side effects for that size person. So we don't have any results that they do expect results in September. So it's possible that we may get vaccine approval for emergency use authorization soon after that, maybe in October, I'm not sure. And then younger ages are also being studied, and probably the earliest that those are going to be approved for use is probably next year, I would guess, for the less than 5-year-olds. I did want to mention variants. They've been a lot in the news. The first variant that we were concerned about was the Alpha variant. That's the one that was first described in the UK. 50% more transmissible compared to previous strains, and 65% increased risk of dying compared to previous strains. There's also been concerns about the Beta and Gamma strains, which were first described in South Africa and Brazil, respectively. They appear to evade vaccine-induced immunity better than other strains. The Epsilon strain is the one that's been described in California, and initially we had an increasing proportion of strains in California because it was more transmissible. But I think the one of most concern now is this Delta strain here. The Delta strain was the one that was first described in India, and it's 90% more transmissible compared to previous strains. So that's obviously a concern, and it really raises the bar in terms of getting enough immunity within our communities to prevent widespread transmission. It looks like current vaccines are effective against that. We don't have that much data yet. And just to show you what's going on in the US, this dark orange portion of the bar is the Delta variant, and you can see over time from April to May to June, and now the latest from July 3rd, these account in the US for more than 50% of the strains that are circulating. So it's really rapidly replacing the other strains because it has an advantage. It's more transmissible compared to other strains. The early result with the vaccine effectiveness against these variants, you can see it's pretty good. It's about 80 to 90% effective for most of the vaccines. The one that didn't work quite as well was the Johnson & Johnson vaccine against the Beta, the South African strain. But otherwise, these appear to have a modest decrease in protection, but still excellent protection. And even when vaccines don't protect against infection, they do an even better job protecting against hospitalization and against death.
So many of you, as parents of young children, probably kind of rolled your eyes at the new mask guidelines that were released, which were very nice, saying fully vaccinated individuals don't need to mask as stringently. But of course, if you have a kid under 12 years of age, this kind of poses a problem, right? Because your kid cannot yet be vaccinated and is still at risk of getting COVID-19. And so many parents are like, Dr. Lena, what do I change anything that I'm even doing right now? And this is a challenging question and really an individualized approach. Of course, the American Academy of Pediatrics, and myself included, it continues to recommend kids under 12 over the age of 2 continue to mask indoors. So when you're in the grocery store, when they're in daycare, when they're around other unvaccinated individuals, to really protect themselves until they can be vaccinated. Of course, if everyone at home is vaccinated, you have a little pod of another family that everyone is vaccinated, then that is where things have been getting nicer, that kids can be unmasked there. I always compare it to like riding a bike and wearing a helmet. maybe you're a great bike rider, but hopefully you're role modeling for your kid, and usually still wear your helmet when you go on a bike ride with them, because it's hard to ask kids to do something like that if you're not doing it yourself. Although kids are really amazing at wearing masks, so that's great. So after all of this, we hope that we have convinced you to get your 12-year-old and up vaccinated. And we're going to stop here so that we can answer some questions for you guys. We did get a lot of amazing questions beforehand, and we hope we were able to answer some of those. One of the questions that we got in the registration was a parent that had a child with a neurodevelopmental disability or autism or just a lot of anxiety. And so on that last link there, the Mind Institute is putting on a vaccine clinic for all people with neurodevelopmental differences. And we will make sure that we share that link. Maybe we can post it in the chat for the participants on how to sign up for that Mind Institute clinic. And then the other great thing is myturn.gov, so myturn.ca.gov. You can type in your zip code and very easily schedule a vaccine if you haven't been able to yet, including here at UC Davis.
Yeah, so just to summarize the main points, there's continuing risk of transmission with a disproportionate impact on Black, non-Hispanic, and Latinx communities and socially vulnerable communities. We've got 3 vaccines in the US. The one that we care about most for children is the Pfizer Biontech vaccine, because that's available 12 and up. And then we need to monitor the new variants for the transmissibility and possible evasion of vaccine-induced immunity. And at some point, we'll be talking about boosters also. So at this point, I'd like to turn it over to Dr. Hartigan O'Connor to see what questions have been coming up.
Yes, thank you so much. And thank you, Dr. Blumberg and Dr. Vanderlist. This is a really helpful presentation. My youngest is 11, and this has been kind of a tough summer to navigate as his friends turn 12 and he can't get his vaccine and who's in masks and who's not. So this has been really helpful for me, and I think for the just about 60 people who are participating in this webinar. So we're moving into the Q&A. We have questions that were submitted in advance. We've got questions coming in from the chat. Let me start with one that I, as a parent of teenagers as well, is close to my own heart. And that is, what can parents say to put their teenagers at ease about getting the vaccine when the teenagers may be hearing about side effects in the news or have friends whose parents are reluctant. So teenagers, of course, have access to much more information than very young children. And so what has been successful in talking to your teenagers to put them at ease about the vaccine?
Yeah, that's a great question. A lot of these things, just like any of the other vaccines that we give in the office, comes down to kind of your family culture is a big part of it. So I always love when like the families all come in together during flu season and they're like, we all get our flu shots. It's just what we do. And kind of explain that they do it to protect each other, to protect their community, elderly people. And so I think that like by empowering teenagers to show like, hey, you have a role in stopping this pandemic. And this is your ability to do that. And then of course, addressing their specific concerns. So you're right there on social media all of the time. They have access to all of these sometimes misinformation and don't have the reasoning skills to kind of walk through that and look to the data and all of that. And so if your team has those questions, like schedule a video visit with your pediatrician or and you don't know how to answer them, or sit down and see like, what are your big concerns with getting this? Is it just that you like think you're going to feel lousy for a couple days, or are you afraid that you're going to have infertility? Like those are two very different things, right? And may require talking them through it in a different way. But teens are so smart and so fun to work with. And so really just try and gauge where they are and what their reservations are. And for most of them, they really do want to do the right thing. And I think that we can convince them to do it.
Yeah, are there good resources to point them toward, websites that are your go-tos that are technical but not too technical, or that are really accessible and useful for smart teenagers who, or the rest of us too, right? that we should be going to first and saying, well, why don't we look at this website, for example?
The CDC is, of course, a reliable source, but I think what's really nice is the Healthy Children website, and that's run by the American Academy of Pediatrics, and that's written for parents, and it goes over a lot of the common questions that parents have.
Thank you. So turning a little bit, I see in the questions some folks who are excited by the new opportunities. There's a question about travel. Can I fly internationally with a 7-year-old, given the changing advice, but also the changing circumstances on airplanes, as you know, the middle seats are now full as travel picks up. An unvaccinated child, is that an international travel? What would you advise?
I think it's okay to travel internationally. The problem is that the US is in one situation because we have a relatively high rate of vaccination. When you're when you're traveling to other parts of the world, you know, some of these areas have relatively high rates of transmission, and some of these areas also aren't really that open. So you need to check. And of course, a 7-year-old is not going to be vaccinated, so they're going to need to mask while on the plane and in airports. And then depending on that, where they travel internationally to, they might, and the masking rules might be different there too. So they just need to plan ahead.
Okay, what about closer to home? I see a question here that says, if you have 2 families that are fully vaccinated, except for their youngest child, can those 2 youngest unvaccinated kids spend time together indoors in close contact? How should we be thinking about that scenario?
Yeah, these are, you know, this is how everybody is viewing this right now. And it's all a risk benefit for individual families, right? And so I think if that is like your closest family network that you trust is vaccinated, is pretty safe in terms of their own exposures, then absolutely, I think it's reasonable that the kids play together unmasked. But again, you have to look at your own situation. Are you living with someone elderly who for some reason hasn't been able to get vaccinated? Or you see grandma, she's like the primary caretaker. So all of these things are individual risk decisions, and that we have to think about and weigh the options on.
As a follow-up to that, I think there's an interesting clarifying question coming through in that chat too, and that is just to try to understand, can fully vaccinated people still get COVID, and can they still transmit COVID? So if we think about that scenario of the vaccinated families, the unvaccinated youngest child, how does that factor into their risk assessment?
The vaccines don't work 100%. So certainly there will be some vaccine breakthroughs. And as we get an increasing proportion of the population vaccinated, we're going to see more cases in vaccinated people. But it's going to be less severe. The concentration of virus is going to be less. And the risk of transmission from somebody who's vaccinated and has a vaccine breakthrough infection is going to be much lower compared to somebody who's unvaccinated and infected. So really being vaccinated not only protects the individual, but protects all those around them also.
So in moving beyond the individual family, there's a question here that says that's trying to make just that kind of calculation, right? So the person asks, okay, I have 3 kids under 6. Do I put them back into school and daycare? Is there any value in waiting until September for FDA approval of Pfizer? I mean, you know, how do you kind of plan the risk over time, or calculate in the percentage of vaccinated people around your unvaccinated children?
You know, even in the closer to the beginning of the pandemic, when levels were high, Dr. Dean and I were both pushing for school reopening. There was a lot of data that showed that reopening schools could be done safely without transmission. And so yes, your kid is still going to be wearing a mask. Yes, hopefully all of the teachers have been vaccinated and they're still taking other mitigation strategies. But there has been no reason that kids should have been out of school this long, in my opinion. And so I am totally on board with getting kids back to school as soon as possible with appropriate mitigation strategies. And the risk is going to be much lower even than it was when some places started going back, because we are getting this great immunity within the community, and we are seeing the numbers go down. So yes, get those kids back in school.
Okay. Let's talk for a moment about a kid who is not quite ready for school, and that is a newborn. So a question says, information on newborn immunity if the mother was vaccinated while pregnant. So is there anything there? And to follow up on this, now that the baby is out, right, the baby's been born, should a parent only allow vaccinated individuals near their newborns? So both are babies born with any protection, and then how do we protect them, the newest among us?
Yeah, so when the mother's vaccinated, she develops antibodies, and those antibodies are transferred transplacentally to the child. So we know that that happens with COVID vaccine as well as other vaccines that are administered during pregnancy, like Tdap vaccine, for example, or influenza vaccine. And with influenza and Tdap, we know that those protect the infant from influenza and from pertussis, from whooping cough. We know that the COVID antibodies are transferred. We have data on that. We don't have data on protection in children, but we would expect that they should get some protection also once they're born if the mom's vaccinated.
And then in terms of protecting the newborn and who should be vaccinated around the newborn, I think we've been saying this even pre-COVID that anyone around, we should cocoon the child is what it's called. So anyone that is spending a lot of time with the newborn should have their up-to-date Tdap booster in that case. So I would 100% include COVID with that now. That they are still, of course, they have any symptoms not coming over to your house, that they're washing their hands before they handle the newborn. And then for moms who may have not gotten vaccinated during pregnancy, but have the opportunity to after the child is born, breastfeeding is another great way to transfer some of those antibodies over to your newborn.
Thank you so much. So we have an even more specific question about other kinds of vulnerabilities in children. So the example that this questioner is giving is a 6-year-old child with several medical complications. So surgery for heart surgery at 2 months for VSDs and ASDs, some risk for arrhythmia, born with some kidney issues. So a number of medical complications and difficulties. And they're wondering, given the risks, particularly they're thinking about myocarditis, is herd immunity. So they're using an idea about is herd immunity safer for him, or is vaccination ultimately, or how do you think about these very vulnerable children?
If they have underlying conditions, including significant heart disease, then they're at risk for more serious complications if they get COVID infection. So it's clear to me that the benefits of vaccination outweigh the risks. And in fact, when Dr. Lena was talking about the myocarditis issue, with the modeling that the CDC did, their modeling suggests that if you vaccinate 1 million children in the highest risk category for myocarditis, that there would be about 65 cases of myocarditis from the vaccine, but that you would prevent over 130 cases of myocarditis from COVID. So clearly your risk of getting myocarditis from COVID, which is more severe, is much riskier. So vaccination is going to be much safer for that child.
That's really helpful. We had a couple of questions about the kind of hospitalizations avoided, or how to understand that slide in thinking about the benefit of the vaccine and thinking about what happened if there hadn't been a vaccination, I guess is the way that,
exactly.
that we want to think about that. Yeah.
Mm-hmm.
So here's another kind of question about guidance as we try to understand information. This is going to be the last one we have time for in the formal Q&A. Why does American Academy of Pediatrics recommend mask wearing for children 2 and up? The WHO and UNICEF advise against masks under 5. Why are there differences in masking recommendations from these different bodies?
I can try to answer that. You know, there's been differing recommendations from the CDC, from WHO, from UNICEF all along. And a lot of that is about just different values in terms of risk mitigation. So for example, in the US, when we talked about social distancing, we talked about 6 feet. Because if there's a 6 foot distance from people who are unmasked, that reduces the risk of transmission by 99%. In Europe, the recommendations was 1.5 meters, so 4.5 feet. With 3 feet, that reduces the risk of transmission by 95%. So, you know, really, there's no magic number in terms of social distancing. And I think it's the same with masking, is that WHO, UNICEF, Europe, you know, everybody has different values in terms of how much effort should be made to protect people and how much of a burden it is. And so you will get these slightly different recommendations throughout the world. And then in the US, of course, we've got so many resources compared to the rest of the world. We have an unlimited supply of masks, and we can do that. It's not a burden in this country because we're a resource-rich country. So I think that's why you do get some of these differing recommendations.
Okay, and you can check in with your pediatrician as you try to sort through this. Well, thank you both very much. This has been really helpful to elaborate on your presentation. I'm going to hand it over to Professor Rochelle Jean-Baptiste, who's the Faculty Director of IDEA at the Office of Diversity, Equity, and Inclusion, which was one of the key co-sponsors of this event, and she's going to finish up for us.
Great. So I just want to talk really briefly about next steps for ongoing conversations and actions in the months ahead about ways to keep all members of the UC Davis community safe. I just want to say that Dr. Dean and Dr. Lena are willing to stay and continue to answer questions. So those of you who want to see all the questions answered, just make sure you stay afterwards. I just want to say this program was brought to you by a couple of institutions at Davis. So one is the Office of Diversity, Equity, and Inclusion, whose goal is to make sure that all members of the UC Davis community not just feel included, but have the resources that they need to advance. And then also Office of Graduate Studies, and also the broad umbrella program called Healthy Davis Together that strives to mitigate and stop the spread of COVID. And so the thing that I just want to say is that even though UC Davis is a learned community of adults, our children, we all come here not just as adults, but we have families, and our children are our most precious resources. And as someone who had children myself when I was in graduate school, and now I'm a parent, I know that oftentimes we can't do our work until we know our kids are safe. So what I'd like to say is that this is not just a one-off event. We're hoping to have more conversations in the fall, particularly as we talk about reopening, sending our kids to school, the new normal, whatever that looks like. So most importantly, in the week ahead, you're going to get a survey where the only way that we know what services and programs we need is to ask. So I'm going to ask you to please fill out that survey and tell us what types of programming, conversations, actions are helpful to you as you think about ways to keep your children safe. And so for students in particular, there'll be a drawing for a gift card to the Davis Farmers Market as a way to just, again, I hope you can fill this out. And so I just want to turn it over to Dr. Dean and Dr. Lena again to answer more questions, and just thank you all for coming today.
Thank you all for having us. It was a great conversation, and I have to hop off, but I know you're in good hands with Dr. Dean, who can answer any of your questions about COVID, and we're happy to come back at any time to continue the discussion as things change. So thanks for having me.
Thank you.
So I see, and I'm gonna be leaving soon as well, but it looks to me like there's a question. If we reached herd immunity before my child is vaccinated, wouldn't it be better not to take even a small risk?
Yeah, I think one of the things with herd immunity that people need to realize is what that means is not no transmission. It doesn't mean that COVID is eliminated. What it means is there's no sustained transmission within a community. So that's what we'd like to get with herd immunity. We know we're going to get continuing introductions of infection within communities because it just seems very unlikely that we're going to eliminate the virus from the whole world. So I do expect ongoing transmission, ongoing risk, and so we would like to have limited transmission, just like we have right now, for example, with measles. If we do get a case of measles within a community, there might be a handful of cases transmitted, but not widespread transmission. That's because we do have relatively high vaccination rates. So I still think that for children who are still going to be at risk for COVID, the people who are going to get infected are going to be the people who are not immune, either because they're not vaccinated or they don't have prior infection. And so we really want to make sure that we get everybody possible protected.
Another question that's coming in has to do with the school district at Davis. So to allow kids to go back to school, they implemented 3 feet of distancing between desks. And since vaccines aren't available for that age group yet, what are the chances of infection if there's only 3 feet of distancing within the classroom?
Yeah, the classrooms they just don't have the physical facilities to distance indoors. So I know a lot of the schools have been paying attention to increasing rates of ventilation, which is great. We know that 90% of transmission takes place indoors compared to outdoors, and that's because outdoors there's basically an unlimited amount of air to dilute the virus. So increasing ventilation works. I think 3 feet is fine in terms of distancing indoors for children. And that's especially if they're wearing masks. And so when the schools open, I've been encouraging the schools to, require children, if they're 2 years of age and up, to wear masks unless they are outside or distanced.
Okay. And then another question has to do about eating in a restaurant. So for a parent who is vaccinated, they'd like to know, is it safe for unvaccinated children to eat inside of a restaurant?
I can tell you the first time that I ate at a restaurant after I was vaccinated, I felt uncomfortable. It just felt weird after all this time to be not wearing a mask in public. It just really felt uncomfortable, but I've gotten used to it. And for children, it is a risk to be indoors and not wearing a mask. And I guess that would depend on the restaurant situation. So for most restaurants, you're going to be relatively distanced from people who are not at your table. The closest people you're going to be to are going to be at your table. So if the people at your table who you're dining out with are your pod, or your family, or they're people who are vaccinated, then I think the risk of infection indoors at a restaurant is going to be really relatively low for children. It's not like other unvaccinated children or the waiters are going to be coming really close to the children and spending an appreciable amount of time with them. So I think it's a safe situation.
So another question about the efficacy of vaccines is, for infants who cannot be vaccinated nor wear masks, would you recommend that vaccinated people wear masks around those children?
The vaccines work so well that I'm comfortable having people who are vaccinated be unmasked around newborns and around other people who are vulnerable to infection. So I'm not recommending masking in that circumstances.
So another question about, could you please repeat the statistics about how many cases of MIS-C are associated with the vaccines versus how many cases are associated with COVID itself?
Yeah, and I just want to clarify, I was talking about myocarditis, and that's different than the MIS-C. The MIS-C is the multisystem inflammatory syndrome in children. That occurs 2 to 4 weeks following COVID infection. It's not been described following immunization. The immunization drives an immune response that's in a way different than the immune response that you get with MIS-C. So for the myocarditis, the modeling that the CDC did, they did a variety of modeling showing low rates of transmission, high rates of transmission, and then they did a cohort of 1 million people vaccinated in the highest risk cohort, which is 12 to 17-year-old boys. They're the highest risk for myocarditis following immunization. And in their modeling, in that 1 million people who were immunized, they estimated that there would be 65 cases of myocarditis from immunization, following immunization. And they also estimate that there would be 130 cases of myocarditis prevented from COVID. So patients who get COVID and then have myocarditis as a complication. So twice as many cases prevented compared to the number of cases caused by the vaccine. And I've seen cases, both cases following COVID and following the vaccine. And I can just tell you that the cases following COVID infection can be quite severe. Kids are in the ICU. They can be very sick and have lasting damage to their heart. Every single case I've seen of myocarditis following vaccination has been mild. These kids have chest pain. It's scary, of course. They're in the hospital for a day or two. They get ibuprofen or other anti-inflammatories, and they almost immediately feel better, and they go home. And their heart function is rarely affected. So it's much milder case of myocarditis compared to if you get COVID. So to me, it's clear that if you're worried about myocarditis, you want to get the vaccine. You don't want to get COVID.
So another question about reproductive health, which continues to be a lot of stories about postmenopausal women who reported to get their periods again after the vaccine.
Yeah, I've heard that anecdotally, and I just don't have any explanation for that. The vaccine for people who've been vaccinated, the first dose, you can have some mild side effects, and the more severe side effects like the high fever, headache, fatigue are reported after the second dose. And the only thing I can think of is that there's two things. One is that it's possible that the stress of that vaccine reaction might result in some hormonal changes that can occur. And the other is that some people have been postulating that people pay more attention to things like periods following vaccination because it's been in the news. And because of that, there's no real change in the menstrual cycles, but that people pay more attention to it. I don't know the answer to that, and I'm not aware of any data on that, any studies on that.
So I'm going to group together two questions about the vaccine and testing. So one person wants to know, it looks like viruses and the variants are here to stay, like the flu. So then why not just wait until there's more data before getting a vaccine?
I think the risk of waiting is that you get COVID in the meantime, that people remain vulnerable. And that's exactly what we're seeing is the shift, since we've done a great job of vaccinating older individuals in the US, what we're seeing is a shift in those getting COVID infection are those who are younger, those who we haven't targeted with vaccines. So right now, virtually the only way that you can die from COVID or be hospitalized with COVID is if you're unvaccinated. 99% of the deaths and over 99% of hospitalizations due to COVID are occurring in unvaccinated individuals. So really that's the risk of not getting vaccinated. We have very solid data of the vaccines protecting against COVID, and with the very promising data protecting against the variants also. So we certainly expect at least partial protection against the variants. If not complete protection, we'll get some partial protection. So I'm really optimistic, and we've got great safety data too, over 300 million doses of COVID vaccines administered in the US, over 2 billion doses of vaccines have been administered worldwide. So I'm very comfortable with the amount of safety data we have at present time.
Okay. So this question is also concerned with the safety data. Again, why would the new vaccine technology not be like other drugs with long-time side effects? And this person has cited, for example, drugs like Accutane and SSRI, et cetera.
Yeah, so the vaccines that are administered, you administer the vaccine, for example, the mRNA vaccine, and the mRNA gets transcribed into the protein, and the mRNA lasts only hours or up to a day or so. And then it's broken down, it's degraded, and it's excreted from the body. So there's no reason to expect, there's no theoretical reason to expect any long-term side effects from that. The longest term side effects that have been seen with any vaccine ever has been with the smallpox vaccine. And the smallpox vaccine is a live vaccine. It does have a lot of side effects. That's why it's not used routinely anymore in the civilian population. And the smallpox vaccine in the past, since it's live, it could multiply and it could affect heart muscle and cause inflammation of the heart. And that could occur up to 5 weeks following immunization. That's the longest ever in the history of vaccines that long-term side effects have been seen. So I'm comfortable that the FDA choosing to have a minimum 2-month extensive safety follow-up with these vaccines, that to me is reassuring.
So I'm going to get back to some questions that are asking specifically about children. So one person says that my children's indoor gymnastics classes do not require the kids to wear masks. They do require adults to wear masks in the building. So they take their kids aged 6 and 3 years old. So she makes her kids wear masks, but they're the only ones wearing them. So is it unsafe for kids who wear masks to be around a bunch of kids who don't wear masks?
Well, I wouldn't say it's unsafe, but it's less safe. The masks work two ways. They protect the person who's wearing the mask from getting COVID, but they also protect those around them in case they're asymptomatic. And we know that 40% of infections in children are asymptomatic, but they can still transmit to others. So it'd be safer if everybody who is unvaccinated was wearing a mask in that situation. But wearing a mask for your children wearing a mask does help protect them.
I'm sorry, I've missed a follow-up question about myocarditis. So somebody wants to know, does the risk abate after a certain period of time, and after how long?
Almost all the cases that have been occurring 2 to 4 days after the second dose of the vaccine. The CDC, in order to make sure they're not missing any cases, they've been messaging that they want to hear about cases, report cases up to 2 weeks later. But really, it really clusters 2 to 4 days after vaccination.
Okay. So here are a couple of questions that have to do with how long is the vaccine, the efficacy. So one person wants to know, how long will vaccine immunity last? And as another one with this, there's another question says, I've heard that there's guarantee that unvaccinated people will get COVID within the next several years. So is this accurate?
So in terms of vaccine protection and how long that lasts, it's only recently, just last week, that there were a couple studies that were released that suggested that they found a serologic correlative immunity, an antibody value, that if you're above that antibody value, that you're protected against infection. So that was really exciting news. We'll see if those are confirmed, but right now the only way to really know how long vaccines last is to follow immunized people and see if the risk of infection increases over time. So those studies are being done. I've heard public statements from both the Moderna and Pfizer from executives that have stated they expect the vaccines to only last about 8 or 9 months and that boosters will be necessary. But I haven't seen any data on that. So I'm not sure where that's coming from. I'm hopeful that the vaccines will last at least 1 year so that if boosters are needed, that we can get yearly boosters similar to getting a flu vaccine. I'm hopeful that they last even longer than that. So we just don't know, and we just need to follow the data. In terms of unvaccinated people, I don't know that I could really guarantee that every unvaccinated person is going to get infected, but it seems likely that if you're not vaccinated and this is a completely new pathogen that nobody's ever been exposed to before in the world before this pandemic started, that eventually you're going to get infected. It just seems natural because you don't have any immunity to this. There's no protective immunity from infection with previous coronaviruses, the normal coronaviruses that cause the common cold, for example. So, it just seems that it's a ticking time bomb. It's going to go off sooner or later if you're not vaccinated.
So yet another question about the vaccine. What do you say to people that are still concerned about long-term side effects? So we know that most side effects occur within the first weeks, but there's still some people who've encountered that have concern about side effects that are many months or years out, and for timelines for which we have no data yet.
Yeah, that just never happened with any other vaccine in the history of mankind. So there is no vaccine that has ever been developed that a new side effect has been found out like a year after you got vaccinated. That just doesn't happen. And it really doesn't make sense scientifically or theoretically, because when the vaccines are injected, you do get an immune response, but the vaccine is then broken down. One of the concerns with the vaccines was that they may develop an aberrant immune response that could worsen disease. And that's been occurred with some other vaccines, for some experimental vaccines. And these vaccines, before they even went into widespread clinical trials, that was looked at to see what direction the immune response was, whether it might enhance disease or not. And they were designed to protect against infection and not enhance disease. So I'm very comfortable that no corners were cut with the development of the vaccines. There's no theoretical concerns for long-term side effects. I just don't see that.
So we have about 2 questions left. So one gets back to the question about masking and not masking. So someone wants to know, if I'm going to the store with my elementary age child and siblings, do I need to wear a mask because they need to wear one?
Well, as Dr. Lena was mentioning, it's nice for you to wear a mask because you're role modeling for your children, because it can feel awkward for them to mask when you don't have to. It might feel punitive to them, for example. So you can mask if you want, but it is optional. I can tell you that I'm fully vaccinated, and I wasn't sure what to do after the mask mandate was lifted, but I found that I feel more comfortable masked when I'm in grocery stores, and when even in outdoor places like the farmers market, which can be quite crowded. So I continue to mask when I'm out in public. I don't mask if I'm walking around the neighborhood or on a sidewalk, but I do if I'm going to go indoors to a store or to the farmers market. I feel more comfortable doing that.
And so just one more comment, it's just thank you for your message about myocarditis. That's a super powerful health message. It should be broadcast wider, but the vaccine is actually reducing the risk and therefore it's protective.
Thank you.
Yeah. So I think we've answered all of the questions. So I just want to say again, thank you to all of you for attending, and that we intend for this not to just be a one-off. So thank you, Dr. Dean and Dr. Lena, that you have this podcast, and I'm sure you're continuing to be available to have people within the Davis community who are disseminating research-driven data, because as we know, though we're all intellectuals, though we're all researchers, our children, when we're talking about our children, our emotional sense or sense of protecting them often also those radars go up. So we're just intending to, again, continue to disseminate research and have forums so that graduate students, our vulnerable population, can continue to have the research that they need and the information they need to make decisions. So with that, we'll just close it off. Again, I just want to urge you to please, please, please answer the survey that you're going to get by the end of this week to let us know what conversations and services you need from there. So thank you all, and we'll see you soon, and I hope you all stay safe and healthy.